fractures constitute femoral neck fractures constitute about 8% of all stress fractures in military personnel. The diagnosis should be considered in any high-risk patient with groin pain. There are two types of stress fractures of the femoral neck. First one is a compression fracture. These are located on the inner side of the femoral neck or medial cortex. This is the medial cortex. يعتبر هذا compression fracture اللي هو low risk. They have a low risk of complicated healing with conservative therapy because the fractured parts are pressed together. Other type of femoral neck fracture is a tension fracture. These are located on the outer side of the femoral neck, lateral cortex. They have a high risk of complicated healing due to tension exerted on the fracture elements. These fractures are at risk for complete fracture and avascular necrosis. If conservative therapy fails, over-reduction and internal fixation is recommended. This is a case of compression fracture of femoral neck. Radiograph is normal, but MRI image show the fracture line surrounded by bone marrow edema. This is a grade 4 fracture. This is a follow-up image at 1 month, 3 months, and 13 months. Show involvement of the fracture to complete fracture. Although this is a low risk fracture لأنه صاير بالميديال side or medial cortex of the femoral neck, the follow-up image after 3 and 13 months show a poor healing tendency. فحتى إذا low risk site ممكن إنه يتحول إلى complete fracture. This is a longitudinal stress fracture frontal X-ray of the femur show linear lucency within the medial femoral cortex oriented along the longitudinal axis of the bone. It's the stress fracture of the femoral shaft. TIBIAL stress fractures. Approximately 50% of all stress fractures in runners and military recruits occur in the tibial shaft. They can occur anywhere in the tibia, but most commonly affect the posteromedial cortex. The majority can be successfully managed non-operatively. مثل ما ذكرنا البوستيروميديال هو low risk site. The less common stress fracture affecting the anterior tibial cortex is more difficult to manage because the incidence of delayed union is much higher. Non-operative management will normally take at least 6 months, so early surgical management may be an option. This is a case of 42-year-old man with a pain in his left knee. The initial X-ray was reported as normal, but T2 MRI image show bone marrow edema in the proximal tibia indicate the presence of the stress fracture. In retrospect, رجعوا للإكس-راي لقوا إنه أكو sclerotic line at the site of the bone marrow edema اللي مبين بالMRI. فهذا اعتبر إنه stress fracture. وإحنا ذكرنا بداية المحاضرة ممكن واحدة من الساينز of stress fracture بالإكس-راي تبين كسكليروتيك لاين. فهذا هو stress fracture. This is a case of 50-year-old male who led a sedentary life. He participated in 10-mile walking contest without any training before. Gradually, pain developed in the lower leg, and in the end, he was unable to walk any further. X-rays show a stress fracture of the lower tibia. Doing too much too soon is a common cause of stress fracture. فأنا حاولت أذكر الهيستوري لأنه كلش مهم بالستريس fracture. بالأخص مرات تطلع يعني الإكس-راي بالبداية تكون normal. فالهيستوري مهم. This is a case of medial malar stress fracture. This is a coronal MRI stir image in patient with ankle pain show marrow abnormality. لكن إنه ظلوا يعني ماكو fracture line, just bone marrow edema. At 11 month follow up CT scan show a clear fracture line. This is post-operative X-ray with screw and lower leg cast at 12 months. Show just a discernible fracture line after 12 months. هذه الإكس-راي show a fracture line at the typical location of the fracture of the medial malleus at the junction of the tibial plafond and the vertical inner line of the medial malleus. فهذا هو typical site of stress fracture. Fibula. Fibular stress fracture account for 10% of stress fracture. They typically occur in distal 1/3. This is the case of athletes with pain just above both ankles, more pronounced on the left than on the right. It's a radiograph made at a presentation were unremarkable, while on scintigraph 2 weeks later show a stress fracture of the distal tibia on both sides. Fractures of the foot, tarsal bones. The navicular bone is the most common site for stress fracture. This is the case of 16-year-old male athletes complain of recent onset of mid-foot pain during training, lasting for several hours afterward. There is a high signal intensity in the navicular bone on the stir image. And also there is a low signal intensity in the T1. It's a grade 3 stress fracture. يعني بس طلع بالتي 1 hypointense without fracture line معناها grade 3. Calcaneus. Stress injury of the calcaneum is due to axial compression forces and is often seen in jumpers. It most commonly involves the dorsal aspect. This is the case lateral X-ray of the calcaneum demonstrate a linear area of sclerosis perpendicular to the trabeculation in the superior calcaneus. This is the stress fracture, sclerosis just. While T1 and the MRI stir image show a low signal unicortical fracture line surrounded by intense pulmonary edema. Metatarsal bones are common sites for stress fracture, about 25%. The metatarsal most commonly affected by stress fracture include second and the third metatarsal bone, the classic march fracture. These are prone to stress fracture because they have a thin shaft but are subject to high level of strain during the propulsive phase of running. They usually do well with non-operative management. This is a case of stress fracture of third metatarsal bone surrounded by tissue edema. This is a case of 15-year-old female with no history of the trauma, recent onset of lateral forefoot pain with walking. Radiograph taken at the presentation was unremarkable, while follow-up X-ray at 3 weeks show complete stress fracture with periosteal of the fourth metatarsal bone with periosteal reaction. Fracture over periosteal reaction. Stress fractures of fifth metatarsal typically occur at the proximal junction of diaphysis and metaphysis and have a higher incidence of delayed and non-union. This is a fracture, stress fracture of the base of the proximal shaft of the fifth metatarsal bone. لحب الأوبليك فيو نشوف stress fracture أوضح. طبعا البروكسيمال fracture of the fifth metatarsal بها أنواع حسب اللوكيشن مالتها. فالسترس fracture يعتبر بالبروكسيمال diaphysis or يعني about 1.5 cm distant to the junction of the meta diaphysis. فهذا السايت هو مال stress fracture. while Jones fracture occur at the metaphysis. وقسم يعتبرون الجونز fracture هو stress fracture، وقسم يعتبرون الجونز fracture يعني منفصل أو مقسوم عن السترس fracture ما له علاقة. Also other fracture at the proximal fifth metatarsal اللي هو الافulsion fracture اللي هو involve the tuberosity اللي هو لازم نفرقه عن الابوفيسز اللي هو secondary ossification center present normally below the age of 16 years. الابوفيسز يكون vertical line while avulsion fracture يكون transverse line ويدخل intra-articular بالتارسو ميتاتارسال joint. ولاحظ انه الجونز fracture ما يدخل بالتارسو ميتاتارسال حتى نفرقهم عن الافولشن همين يدخل بالانترميتاتارسال joint. Also there is يعني accessory bone اللي هو called os vesalianum هذا rare present less than 1% of population. This is the oblique view of right foot showing displays transverse fracture in the proximal metadiaphysis of the right fifth metatarsal bone. This intra-articular avulsion fracture of the base of the fifth metatarsal bone associated with soft tissue edema. بنلاحظ مثل ما ذكرنا الافulsion fracture اللي هو يدخل بالتارسو metatarsal joint intra-articular. Sesamoid bones are uncommon sites for stress fractures. This is a case of 14-year-old male soccer player with persistent plantar forefoot pain. Stress fracture of the medial sesamoid of the grade 2 is indicated by the high signal intensity on the stir image, and also CT show sclerosis of the sesamoid indicate the stress fracture. Sacrum. Sacral stress fractures are caused by vertical body forces from the spine to the sacrum and then dissipated onto the sacral ala. These may present as a low back pain or buttock pain, mimic disc disease, sciatica, or sacroiliac joint pathology. These fractures more commonly affect the female runners. MRI is highly sensitive in the detection of early sacral fractures, but as diagnosis may be difficult, CT and scintigraphy may also be required. Bone scan classically shows uptake paralleling the sacroiliac joint. CT scan may show a linear sclerosis with cortical interruption. MRI may show linear signal alteration parallel the sacroiliac joint. This is a case of coronal and axial T1 MRI show a linear area of decreased signal intensity in the left sacrum surrounded by low signal bone marrow edema. This is the T2 coronal T2 and stir image show the fracture line surrounded by high signal bone marrow edema. This is the axial image. Short notes about the spondylolysis. It is a defect in the pars interarticulars of the neural arch, the portion of the neural arch that connect the superior and inferior articular facets. It is commonly known as pars interarticularis defect or more simply as pars defect. Epidemiology, spondylolysis is present in about 5% of population and higher in adolescent athletes. It is more common in men than in women. Clinical presentation. Spondylolysis is commonly asymptomatic. Symptomatic patients often have pain with extension and or rotation of the lumbar spine. It is a common cause of low back pain in adolescents and in particular athletes. Pathology, spondylolysis is believed to be caused by a repeated microtrauma resulting in a stress fracture of the pars. A dysplastic pars is usually present. Genetics are also believed to be a factor. Location, about 90% of cases of spondylolysis occur at L5 level and 10% occur at L4 level. The process may be unilateral or bilateral. Association, about 65% of patients with spondylolysis will progress to spondylolisthesis, which is seen radiographically in 25% only. In most patients, this occurs before the age of 16. Also, it is associated with the spina bifida occulta. Radiographic features, imaging features depend on the age of the lesion. On plain radiograph, limited sensitivity compared to the CT. It may show Scotty dog sign. On oblique radiograph, a break in the pars interarticulars can have the appearance of the collar around the dog's neck. وراح نشوف بالصور. Inverted Napoleon hat sign. It is a radiological sign seen on the frontal pelvic or lumbar radiograph at the level of the fifth lumbar vertebra and the sacrum. It is seen when there is a bilateral spondylolysis with marked anterior listhesis of L5 on S1 vertebra, or marked exaggeration of the normal lordosis at the lumbosacral junction. This is the oblique view of the lumbar spine, show the appearance of the Scotty dog. The ear of the dog represented by superior articular process, the frontal leg represented by inferior articular process. البارس interarticulars هو الاريا ما بين السوبريور and الانفيريور articular process اللي هو هذا يعني neck of the dog. The ear represented by the pedicle and the nose represent the transverse process. This is the case of the pars defect or spondylolysis appear as a lucent line أو collar. فهذا هو السكوتي دوغ with a collar أو البارس defect. This radiograph shows the inverted Napoleon hat sign on the frontal view, indicative of the bilateral L5 pars defect and spondylolisthesis. On frontal X-ray of the sacrum, this is the inverted Napoleon hat sign. This is the Napoleon hat. فهي السايد تكون inverted. CT and MRI, there is a white canal sign may be present on sagittal images when there is a spondylolisthesis, deviation of the spinal process or sclerosis of contralateral pedicle. This is the MRI still image show the pars defect, the lucent line with bone marrow edema. Classification of spondylolysis, it is called Hollenberg classification. This is mostly based on MRI features. Grade 0, normal pars, MRI show no signal abnormality and the pars is intact. While grade 1, stress reaction, MRI show marrow edema plus intact cortical margin. Grade 2, incomplete stress fracture, MRI show marrow edema with incomplete cortical fracture or fissure. Grade 3, acute complete stress fracture, MRI show marrow edema plus complete cortical fracture extending through pars interarticularis. While grade 4 is a chronic stress fracture, MRI show no marrow edema, while fracture completely extending through pars interarticularis. Treatment and prognosis. Surgery is only considered in rare circumstances, as most cases respond to conservative management. Differential diagnoses include osteoid osteoma and osteomyelitis. Insufficiency fractures are a type of stress fracture which are the result of normal stress or on abnormal bone, as we said. Etiology, osteoporosis is the most common cause of insufficiency fractures. Disrupted bone mineral homeostasis include hyperparathyroidism, DM, and osteomalacia. Bone remodeling include Paget disease and osteopetrosis. Collagen formation include Marfan syndrome and fibrous dysplasia. Medication include steroid, chemotherapy, and radiation therapy. Hello.
نسمعك بس ما ادري منو واحد فاتح المايك.
Vertebral fractures.
Okay, استرسلي.
Location of insufficiency fracture include vertebral fracture اللي هو crash or wedge fracture, very common. There is marrow edema limited to the vertebral body. if there is extension of abnormal signal into the pedicle, this suggests underlying lesion معناها راح يدخل بالpathological fracture not insufficiency fracture. Other sites of insufficiency fracture include sacrum اللي هيطلع على شكل هوندا ساين حنشوفها بعدين بالبون سكان. neck of the femur, proximal third of femur اللي هو bisphosphonate related proximal femur fracture at lateral cortex. راح نفرقها بعدين على اللوزر زون اللي يكون بالميديال cortex. فالinsufficiency fracture occur at lateral cortex. Other sites include pubocremi, sternum, fibula, and tibia. Radiographic features. Early diagnosis is best made with bone scan or MRI, as plain films may initially appear normal. Plain X-ray may, as we said, may appear normal initially, or may show periosteal reaction progressing to callus formation in diaphyseal fractures, or it may show linear sclerosis and cortical thickening more frequent in metaphyseal and epiphyseal fractures. MRI is as sensitive as bone scan with added benefit of higher specificity both in isolating the exact anatomical location and in distinguishing fractures from tumors or infection. It may show a low marrow signal T1 and high marrow signal on T2. After contrast, the enhancement may be intense. On bone scan, there is increased activity at the site of the fracture. This is the lateral X-ray of the lumbar spine show L1 vertebral body compression fracture. This is the compression fracture of the L1 vertebra. Wedge compression fracture of the L1 appear on MRI. This is the L1, about 30% anterior height reduction associated with diffuse marrow edema. No retropulsed bone fragment and intact posterior column. حتى يعتبر هذا هو osteoporotic fracture not pathological fracture. الوجه fracture ممكن يعني يكون acute or old fracture. فبالacute fracture نفرقه بالإكس-راي or CT. There is anterior step defect. هذا الانتيريور step defect بالcortex, and there's a line of condensation caused by trabecular impaction with a preserved posterior vertebral body height. While in old osteoporotic fracture, there is a wedge deformity of the vertebral body with intact cortex and normal trabeculation. This is the CT scan, sagittal and coronal image show the both acute and old osteoporotic fracture. الوايت arrows represent الacute fracture في اللحظة الستيب ديفكت اللي موجود بالكورتكس والtrabecular condensation أو الامباكشن. While اليellow arrows indicate chronic fracture, just wedge deformity. This is Honda sign of sacral insufficiency fracture on isotope bone scan. There's a bilateral vertical uptakes connected by horizontal band between them فتبين على شكل H shape. Treatment, it depends on the location and whether the fracture is complete or incomplete. So options may include conservative management, plaster cast, internal fixation, vertebroplasty, or kyphoplasty. Treatment of underlying cause of bone weakness is also essential. Last subject about loser zones. It's also a type of insufficiency fracture. They are wide transverse lucencies with sclerotic borders traversing partway through a bone, usually perpendicular to the involved cortex, and are associated most frequently with osteomalacia and rickets. Also, they are known as cortical infarction, Milkman lines, or pseudo-fractures. Etiology, osteomalacia is the most common cause and is the strongly favored diagnosis when the loser zones are bilaterally symmetrical and in the classic location, such as the axillary border of the scapula, ribs, or posterior ulna. Other causes include renal osteodystrophy, fibrous dysplasia, hyperthyroidism, Paget disease of the bone, X-linked hypophosphatemia, osteogenesis imperfecta, and hypophosphatasia. Location, a loser zone occur in the same locations as the insufficiency fractures, and the weight-bearing bones include pubocremi, medial femoral neck, medial proximal femoral shaft. هذا اللي ذكرنا إنه يكون بالميديال. loser zone تكون بالميديal side, while insufficiency تكون bilateral cortex of the proximal femoral shaft. And then weight-bearing bones, they often occur along nutrient foramina and represent the true pseudo-fracture. These include lateral scapula, posterior proximal ulna, ribs, and iliac wing. This is the X-ray of the pelvis show loser zone in both the superior pubic rami. Also, this X-ray of the pelvis show focal lucencies along the inner margin of the femoral neck. هذه اللوسنسي إذا واضحة. The lucency is oriented perpendicular to the cortex and does not span the entire cross section of the femoral neck as typical fracture would. Also, there is a minimal sclerosis associated with the lesion, unlike the typical stress fracture. This is the loose person. This is the references. Thank you.
عاشت ايدك